Welcome to GastroVision. Today, you're going to learn about the EUS characteristics of some important cystic lesions in the pancreas. Let's look at each one image by image and understand the key differentiating features. Serous cystic tumor, serous cystadenoma. In this first image, you can see a multicystic tumor in the pancreatic head, large arrows. The lesion contains multiple small cystic spaces, small arrows, with thin fibrous septations, giving it a sponge-like or honeycomb appearance. This is a serous cystic tumor of the pancreas. Serous cystadenoma is a benign cystic neoplasm with no significant malignant potential. It is most commonly seen in women, particularly in middle age. These lesions usually do not require surgical resection unless the patient is symptomatic or the lesion causes biliary or duodenal compression. So remember multiple tiny cysts, thin septa, and a honeycomb pattern point towards serous cystadenoma. Now in the next image, you can see dilated side branches of the pancreatic duct, forming a multilocular cystic mass. The cystic mass is smaller than 3 centimeters, and importantly, there is no solid component or mural nodule. This represents the low-risk group of branch duct type IPMN, or intraductal papillary mucinous neoplasm. IPMN is characterized by cystic dilatation of the main pancreatic duct or its branches due to intraductal growth of mucin-producing neoplastic epithelium. Based on the duct involvement, IPMN is classified into main duct, branch duct, and mixed types. A key feature that helps differentiate IPMN from mucinous cystic neoplasm, MCN, is communication of the cyst with the pancreatic duct. MCN usually does not communicate with the ductal system. So when you see a small multilocular cystic mass without mural nodules, think low-risk branch duct IPMN. In this next image, again, you can see dilated side branches of the pancreas forming a multilocular cystic mass. But here's what's different. The cystic mass is larger than 3 centimeters, and you can clearly see a solid component or mural nodule inside the lesion. This finding puts it into the high-risk group of branch duct type IPMN. Such lesions have a higher potential for malignant transformation and generally warrant surgical resection or closer surveillance. And finally, in this image, you can see a monolocular cyst in the pancreas. No septations, no mural nodules. However, there is internal echogenic debris visible within the cystic cavity. This is typical of a pancreatic pseudocyst. Pseudocysts occur as a sequela of acute or chronic pancreatitis or due to pancreatic trauma. They represent collections of pancreatic fluid surrounded by fibrous tissue, not a true epithelial cyst. On EUS, the presence of internal debris, absence of septations, and clinical history of pancreatitis help confirm the diagnosis. To summarize today's learning, serous cystadenoma, multiple small cysts, thin septa, honeycomb appearance, benign, no malignant potential. Low-risk branch duct IPMN, smaller than 3 centimeters, no mural nodule, duct communication present. High-risk branch duct IPMN, larger than 3 centimeters, mural nodule present. Needs follow-up or resection. Pseudocyst, single cyst, no septa or nodules, with internal debris. History of pancreatitis. If you found this video helpful, don't forget to like, share, and subscribe to GastroVision for more EUS-based learning videos. Stay tuned for upcoming sessions where we'll decode more real pancreatic and biliary EUS cases, one image at a time.